Well, first of all, I want to thank you on behalf of ICAD, Portuguese Institute of Addictive Behavior and Dependencies, and also thank you personally. It's a pleasure to share this space with you. Finding time to pause and think about our work is always precious. And I like to share my standpoint. Well, I am, well, you already know, I am a clinical psychology with training in psychodynamic psychotherapy, and I work within a public treatment team, but closely followed harm reduction services in recent years, especially in Lisbon. I deeply believe in harm reduction, far beyond substance use. As its core, it's about recognizing people in their full complexity. And I believe that understanding the social and institutional framework helps make sense of how interventions work. So, at the risk of being boring, I'll start there. Portugal is well known for its approach to substance use and addiction, but to understand it, we need to go back to the 80s, 90s, a time when the country faced a major drug crisis. After decades of fascist dictatorship, 74 April Revolution marked a turning point, bringing democracy, decolonization, and significant social and economic transformation, but also exposed deep structural inequalities, poverty, precarious housing, and limit access to healthcare. Substance use increased as drug became both an escape and a response to social and psychological distress. These dynamics laid the groundwork for the public health approach to drug policy that then emerged. In 98, the government bring together a group of experts to think the national strategy to combat drugs. Was groundbreaking and still is today. It rejects the dominant back then war on drugs approach, and the strategy itself states the war on drugs is one of those battles where the actors, driven by emotion, believe they can win without thinking. The result? Neither has the drug phenomenon been defeated, nor do we have solid evidence-based knowledge about it. At the time, drug-related problems affected multiple layers of society. It was in this context, under the presidency of Jorge Sampaio and the government of António Guterres, now UN Secretary General, that the political consensus was reached and made the decriminalization of drug use possible. This marked a shift from a punitive approach to one based on public health and human rights. Since 2001, anyone caught with an illicit substance for personal use is referred to a drug addiction dissuasion commission, and instead of facing criminal charges, if needed, they can be referred to treatment or harm reduction services as low threshold methadone programs. And at the time, within National Health Services, multidisciplinary treatment centers were already expanding across the country as harm reduction programs. This legal shift was then reinforced in 183 2001 law, which established a set of sociosanitary structures aimed at reducing risks and harms associated with drug use, like needle and syringe programs, low threshold methadone programs, drop-in centers, houseless shelters, outreach teams, drug checking, and safe consumption sites. Even though public responses to drug-related problems were started way before, and needle and syringes exchange national program start 93, as other harm reductions initiatives. This legislation finally gave stronger legal protection to both the people who use harm reduction services and the professionals who work within. Here we are now. In 2025, this policy has been effective. It dramatically reduced HIV transmission, hepatitis B and C, syphilis, overdose death, drug-related stigma, and it helped take the issue out of the criminal justice system and into the health and social care system. But success also brought a new challenge. As the public perception of drug-related issues faded, so did political and financial investment. And 2003 last ICAD reports highlight challenges in the post-pandemic context that indicate an underinvestment in harm reduction services. While there has been a decline in the prevalence of some substance, the report points to an increased problematic use, particularly of cocaine and crack cocaine. And it also notes difficulties in implementing effective responses due to health service restructuring and institutional changes. There is a growing demand for treatment now and for harm reduction services too, as well. But response has not kept pace. And today, with the housing crisis and the rising social inequalities worldwide, we are starting to see new challenges emerging in substance use. At the same time, the political shifts happening worldwide leave us deeply concerned. We see regressive policies gaining ground, pushing for more criminalization and punishment, ignoring decades of evidence that show the importance of harm reduction in public health approaches. Reality reminds us every day of emerging needs, inclusive responses, approaches that embrace diversity, trauma and culturally sensitive care, and truly embody a person-centered approach in all its dimensions. Harm reduction in Portugal is mostly led by NGOs that apply for ICAD public funding based on regional needs. So even though there's a solid national strategy, services can vary across regions, shaping inequities. With that in mind, I will give you a quick picture of Lisbon, is the area I know best. And here in Lisbon, there are 3 ICAD integrated response centers, which provide mostly addiction, which provided addiction treatment care, a detox unit, and free access to several therapeutic communities. And ideally, all these services should work in coordination with harm reduction services. Right now, Several harm reduction structures are in place here in Lisbon, mainly run by NGOs, each playing a crucial role in providing support in reducing risks for people who use drugs, particularly those who do not or cannot engage with traditional services. With a proximity-based approach, working directly in locations where substance use happens, by meeting people where they are, these services provide a wide range of harm reduction services, harm reduction materials, naloxone testing, medical care, vaccination, social support. There are one mobile low threshold methadone program with 5 stops across the city. Managed by Aros do Pinhal, and with about 100 and 1,300 users, people using. And 2 outreach teams managed by Crescer, 2 drop-in centers, a community-based center managed by GAT. It's GAT in Moraria. It's in a historically diverse and migrant-rich neighborhood where people can access free and anonymous testing, access to treatment for HIV, hepatitis B and C, and syphilis and TB, as well as a safe consumption site, peer support, and social services. And another drop-in managed by Cosmic Care, originally focused on harm reduction in festival settings. It has since expanded to provide a range of services: outreach work, drug checking, counseling, emergency psych care, information and support, harm reduction training, and gender-based violence awareness. There are one houseless shelter, harm reduction houseless shelter for people who are using drugs and or alcohol that are managed by Vitae, and 2 supervised consumption sites, a mobile unit, the first one in Portugal, of the 4 now existing, 2 in Lisbon and 2 in Porto. This mobile unit was started in 2019 in bringing injection safe place to different areas on the city. And then a fixed site finally established in 2021, providing a more stable structure where people can use substances under professional supervision and have access to a range of different services also. The mobile unit is managed by Médicos do Mundo, and the fixed site by Aros do Pinhal. Yes, although safe consumption sites were already in 1999 national strategy, and in the 21 law, it took 2 whole decades for the conditions to align and actually make them happen, 20 years. Safe sites are widely recognized as a success, helping prevent overdose, reduce public consumption impact, and connect people with healthcare and social services, but their existence is constantly challenged. Their location in the city is a permanent battleground where fear, stigma, and not in my backyard attitudes clash with evidence-based public health measures. As you know, this isn't unique to Lisbon. Marginalization is never just about individuals. It's systemic, deeply rooted in history, and shaped by who society see as worthy of care and who we choose to push for further into invisibility. Regardless all of these challenges, these services exist and have been doing an incredible job despite numerous difficulties. In recent years, we have witnessed important changes, particularly in shelter responses. It is important to highlight that until COVID pandemic, people with active substance use faced significant barriers to accessing shelter in Portugal. There were simply no options available for them, except for harm reduction shelter I mentioned earlier. But even there, certain barriers often led to people with active substance use being pushed out. During the pandemic, confinement and even prohibition of drinking in public health. Oh no. Let me. We see. Let me know. I lose myself. So I was saying that during the COVID pandemic, people with active substance use faced significant barriers. Even there, certain barriers often led people with active substance use, even in the harm reduction structures, people with active substance use being pushed out. During the pandemic, confinement and even the prohibition of drinking in public spaces were mandatory, and this was especially challenges for people experienced homeless with active drugs. And this situation required specialized solutions. And Lisbon municipality Lisbon municipality transformed a sport center in a homeless shelter where people with active substance use were welcome, and it was more than food and shelter. The low threshold methadone program and the mobile supervised consumption program included a stop nearby the center. A low threshold alcohol program was created, and people could enter as they and leave as they pleased, and until and pets are also allowed. And towards the end of the pandemic, we were asked to develop a training plan for the teams of 3 shelters in Lisbon. We developed a harm reduction collaborative training, and it revealed just how unprepared many services are where it comes to working with people to use substances. Many professionals admit that before the training, they lacked knowledge and tools to engage effectively. It also highlights the resistance that often exists in these services when it comes to shifting perspectives. Many professionals have internalized the idea that helping means getting people to stop using substances. So it is difficult for them to accept that their role could be to support people, even if they continue to use. At the same time, something powerful can happen. The more professionals understand that they are not expected to fix people, the more open they become to actually supporting them. Even when perspectives on substance use, safety, and support beginning to shift, real transformation is a long-term process and require ongoing secure training spaces. But training is essential. Harm reduction, trauma-informed care, and gender and cultural sensitive practices are crucial in these settings. When we think of harm reduction beyond the immediate reduction of risk, our harm, we find a way to reach the other person, an encounter that can promote change and even be therapeutic, because therapeutic relationships happen everywhere in daily interactions, and they may seem small from the outside. A quick conversation during a needle exchange, a moment to support while someone is using, handing over the key to a locker. One moment that illustrated this happened in a shelter when we arrived to training. It's one woman that after arriving at the shelter and putting her belongings in the locker, a woman, she came and to return the key, the locker key to the staff member. And the staff member said, but it's for you, it's yours. And the look on her face, when she heard those words, said more than words ever could. She hesitated for a moment and asked, it's for me? And then, almost whispering, as if he trying to convince herself, she repeated, it's for me, it's mine. These are the moments where trust is built, where people start to consider that maybe they are worth being cared for, where healing, slow, unpredictable, and fragile, begins to take shape in ways that do not fit traditional model cares. There has been significant progress, but it's still important to recognize that this challenge is still far from being fully addressed, especially outside Lisbon. Harm reduction cannot exist in isolation. It is not enough to have well-designed harm reduction programs. We need shelters, healthcare, social services, housing programs, and employment initiatives that integrate this approach. Without this, people continue to fall through the cracks of fragmented systems. Ensuring continuity of care across different services is crucial. People who use drug frequently navigate multiple systems, healthcare, social systems, housing programs, yet these systems often operate in silos, each with different rules, expectation, and approaches. Harm reduction must remain a guiding principle across all these settings, even when the goal is abstinence. A person-centered approach means acknowledging that recovery it's not a linear path and that rigid service structures can create unnecessary barriers to care. Let me share an example for my clinical practices that I believe illustrate this idea. When I first met José in a multidisciplinary treatment team, he has already been through 11 detox programs. He arrived asking for one more chance at getting clean. Over time, we explored what function did his substance use serve, why did he equate treatment with full abstinence, how could he make choices that felt truly his own. And the turning point came when it had to choose between another detox program or a low threshold methadone program. At first, methadone felt like failure, but as we talked, it became clear that this struggle wasn't about treatment itself. It was about identity, shame, and ingrained ideas of what getting better was supposed to look like. Harm reduction, in this case, wasn't about choosing between abstinence and drug use. It was about creating space for him to exist beyond those two options, integrating and coordinating services are also essential. When the institution impose one-size-fits-all models and expect individuals to conform to pre-existing structures, they risk exacerbating suffering, reinforcing trauma and stigma, and in some cases, undoing years of progress. True harm reduction is not about choosing between abstinence and drug use. It is about creating a system that adapts to the real needs rather than forcing people to adapt to rigid systems. We can't deny reality. People have always used substance, always. We use them to feel good and to feel less bad, to seek pleasure, to numb pain, to connect, to escape, to belong. Substance use is not a failure of morality, willpower, or intelligence. It is a part of being human. Even when drug use loses its original social context, it continues to serve a psychological function. People don't use substance arbitrarily. They use them in ways that make sense within their personal histories and social environments. When people struggle with drug use, they are suffering in an attempt to survive. Substance use, often a way to cope with trauma, can become both harmful and stigmatizing. That stigma, in turn, makes them even more vulnerable to re-traumatization in a society that too often judges rather than understand. This is why compassion is at the heart of harm reduction. Rather than focus solely on substance use, a compassionate approach seeks to understand the person behind it, their struggles, needs, and experience. By meeting people where they are, without judgment, we create the conditions for safety, dignity, and meaningful change. It is easy to say we work from a non-judgmental place, but the truth is we all have bias. Some conscious, others deeply unconscious. If we fail to acknowledge this, we risk making assumptions, pushing for changes that reflect our own expectations rather than the person's needs, and ultimately failing to meet people where they really are. Harm reduction is both compassion and pragmatic. It recognizes the complex interplay between individual experience and systemic factors. It requires understanding the lived realities of people who use drugs and advocating for approaches that respect their humanity and context. More than just a set of services, harm reduction challenges broader societal structures, promoting social justice and equity. Harm reduction, then, is not just a public health approach, it is a radical act of recognition of suffering, of autonomy, of human rights. Thank you.